Physical examination, leathery pericardial friction rub can be heard. Quote unquote, leathery. ST elevation, now, stage 1, hours to days. Okay? And then a couple other things that I will point out to you. First and foremost, if it's within stage 1, hours to days, very similar to acute myocardial infarction in terms of what? Transmural, you find what can I change on EKG? It was called ST elevation. But if I told you 2-3 AVF, you would then be thinking what? Right coronary artery. What if you find an ST elevation in every single lead? Huh, wow, that's a myocardial infarction in every single lead. Are you kidding me? No. This is not Kawasaki. And even Kawasaki wouldn't be such diffuse ST elevation, right? So all leads, you might find ST elevation. But what else is important? Pay attention. PR depression. Close your eyes. Tell me about the PR interval. Isoelectric or wavy? Isoelectric. How important is that PR interval? How about ridiculously important? What do you mean? Well, PR interval is between 0.12 to 0.2 seconds. That you must be firmly etched in your head. 0.12 to 0.2 seconds. Why is that important, Dr. Raj? Because you've heard of AV block. So when we do arrhythmias, when we do first degree, second degree, Mobitz type 1, Mobitz type 2, we'll talk about that PR interval, won't we? And with AV blocks, what happens at PR interval? It's prolonged. It's isoelectric, okay? So separate topic at a separate time, however, clinically significant. Isoelectric. This is PR depression, where you take PR and associate this with the augmented lead, AVR. Clear? You'd find this more so with acute pericarditis. There are no Q waves, and by that, we don't mean that there's no negative deflection. You do not find the exaggerated negative deflection that you might find with chronic MI. That must be understood. And every once in a while, later on in stages that you get with acute pericarditis, which is a bit too much information, but nonetheless, let me just point it out that there might be diffuse T-wave inversions later on in stage 3 and such. But for right now, let's just stick with the basics. Stage 1, ST elevation, all leads. PR interval, AVR, R and R. Let that help you. Echo, effusion. So half of your patients, you might actually find effusion taking place in your pericardial cavity. Now, if you take a look at this EKG, you will take a look at most of these leads. And what are you looking at? ST elevation, ST elevation, ST elevation. See some really good ones right there at the bottom. Lead 1 you do. So you find ST elevations in every single lead. Would they give you all 12 leads? Of course they would. But you have to make sure you know as to what you're looking for, huh? And based on the history of your patient, and then you take a look at the EKG, you cannot go wrong. So if your patient is telling you leaning back, it hurts, stabbing chest pain, you take a look at the EKG and you find all these ST elevations, acute pericarditis. Acute pericarditis here as well. Every single ST elevation, every single lead, ST elevation.